you, Janki.
Thank you, sir. Good evening, everyone. Welcome to the platform of Orthopedic and Research Education Foundation India. And I'll hand over to our chairman, Dr. John Mukhopadhyay, to introduce the speaker.
No, okay, welcome everybody to this uh, webinar today, which is going to be dealing with cervical spinal injuries for sub-axial cervical trauma. And we have with us Dr. Gautam Prasad, who's our spine surgeon here in Patna at Paras HMRI Hospital, who's going to do the presentation. I think cervical spine injuries are an area where the management becomes very critical, both in terms of life as well as neurological recovery. And it's important that everyone understands at least the basics of identifying which patients need urgent treatment, which can be managed conservatively. So over to you, Gautam.
Yes. Good evening, everyone. So we'll be talking on subaxial spinal injury. I'm thankful to Dr. John sir, Dr. Janki, and Dr. Ashok for this opportunity. So as sir said, cervical injury is a very complex injury because along with cervical injury, there are many times other injuries which are associated. And many times cervical injuries, patients end up with various comorbidities, and even there are at times mortality associated with cervical injury, especially in higher cervical injury. What in this talk we will be going through is the subaxial, that is C3 to C7 cervical spine injury. So whenever a unconscious patient comes, or there is a history of a very significant trauma, multi-vehicular accident, or a blunt trauma while playing, or violent mechanism which is actually the cause of injury, one should be very suspicious about cervical injury, especially in an unconscious patient where the history is not the actual history may be lacking, or the patient presents in a conscious state but with gross neurological deficit. One should be very suspicious of cervical injury. And many times, if this is missed, failure to anticipate a cervical injury in a polytrauma case can lead to secondary injury in the form of sudden movement across the fracture site, which can lead to further deterioration of the neurology of the patient. Whenever we suspect a cervical injury, the first and foremost thing is to immobilize the cervical spine. That can be done with the help of a rigid collar. And we have to see to it that whenever we transfer the patient is transferred just like we hold a log. So more than 4 or 5 persons should be involved in transporting a person, and the person should be transported with the cervical spine totally immobilized on a trolley or a slider. Initial diagnosis should be made based on the clinical examination, right from inspection, palpation, as we do in all the injury cases. There should be inspection and palpation of all the bony points should be done. While examining the cervical spine, we should take care that we don't cause further movement of the cervical spine. At the same time, we are able to palpate the spinous process. Any tenderness which can be elicited in a conscious patient in a cervical spine might be the cause, might indicate towards a injury. Also check out if there is sudden gap or sudden prominence of the spinous process, or there is significant spasm associated with the neck. In the same time, if the patient is conscious, also check out whether the patient has any other features of prolonged immobility of the spine, like restriction of mobility. Because many times this older patient with DISH, that diffuse idiopathic spinal hyperostosis or ankylosing spondylitis, they give a history that the spine was, my neck has suddenly become more free after the injury. So mind you, the neck might have been immobilized before because of the pathology. And because of the injury, there is a fracture across the segment, which has led to increased mobility. So whereas the spasm will lead to decrease in mobility, a sudden increase in mobility in a previously rigid spine is indicative of a fracture. So that has to be emphasized. Then do the neurological examination, which should be sensory, motor, reflexes, and rectal examination as well. Based on the sensory examination, we can very well, and the neurological myotome which is involved, we should be fairly having a good idea at the end of examination as to what the level of injury is, if there is any. And once we are sure about the injury level, then we should go for imaging. Now, the common practice is the basic thing which is available everywhere is X-ray. Now, doing an X-ray of a cervical spine is equally very difficult. So, if possible, accompany these patients. Get a proper X-ray of the AP as well as lateral view. By supporting the neck, we have to ask the radio technician to properly place the films, the cassette, so that there's no further movements across the fracture site. Also, one should note that many times turning the patient is not a good idea. So go for lateral shoot through X-rays. And once that is done, what to see in it? So in the AP, one has to check out if all the facets are aligned well. If there is a dislocation, specifically if there is a unifacetal dislocation, the AP will be malaligned. The facets in the AP view will be malaligned. And as shown in the lateral view, these are the various spinal lines. So if there is any breakage of this line, that is the anterior spinal line, the posterior spinal line along the posterior part of the body, or the spinolaminar line and the spinous process. So if there is any break in the line, that is indicative of some malalignment. So if there is more than 3.5 millimeter of displacement, or the angulation is increased by more than 11 degrees, that we should be very careful. And then go for the next imaging, which should be MRI or CT. Yeah. So in MRI, what to see? So mind knows the thing eye sees what mind knows. So we should know that if there is an injury in the cervical spine, it can either affect the body, the disc, and the posterior ligament structures, and the spinal cord in between. So in body, there can be a fracture, the disc can get disrupted, and there can be protrusion of the disc. Posterior element, there might be fracture, specifically the posterior ligaments. So if the ligaments are fractured, we see a edema on the T2 weighted images. And then comes the cord. The cord injury, whether it is edema or contusion, that should be well appreciated on T2 as well as T1 sagittal images. Now, there are some examples. Like in this X-ray that we see, there is actually dislocation of the facets of C3 vertebra over the C4. Now, if you can appreciate the alignment of the anterior spinal line, the posterior spinal line, and the spinolaminar line, all are disrupted. And if we appreciate very well here, we can appreciate very well here that the C3 facet has jumped over the C4 facets. Now, after this, there is a comparative MRI imaging on the right side. Now, in MRI, we also note while doing the MRI whether the alignment has got changed or not. Firstly, secondly, check out the posterior disruption, which is very well evident over here. And is there any disc component which is from the front causing any compression of the cord from the front? So all these things has to be taken into account. Now, at times at a lower cervical spine, specifically like this, where there is C6, C7 or C7, D1 subluxation, dislocation, it's quite likely that it might get missed. So at times we have to pull the shoulders down and then get an X-ray to have a better view of the junctional areas. This disruption in a traumatic spine is not very common, but one has to be very careful that alone the disc can get disrupted and there can be a disc herniation. In this case, there is subluxation along with disc herniation, and in the axial, if we see, not only the disc prominence is seen, but we also see that the posterior element, the posterior muscular edema is seen. Now, if you are very careful in this, I don't know whether you are able to appreciate the cursor over here, but in this axial, we have to also look at the vertebral arteries. So if the vertebral arteries are injured, then the blackening that we see on a T2 image on the vertebra, that vertebral artery, it will be totally white, or there might be a C-shaped vertebral intimal injury. So these things has to be appreciated on axial images. Why it is very important? Because cervical spine fracture dislocation many times can be accompanied with asymptomatic vertebral artery injury, and this intimal injury can lead to further hemorrhagic presentation, can lead to posterior inferior cerebellar artery syndrome, which can get the patient into coma. So all those things has to be taken care of. Now, in this X-ray, as we can appreciate, there is a totally fused vertebrae. So he is a case of 80-year-old guy with ankylosed spine. Now, if we look properly in the X-ray, there is a posterior subluxation of C2 over C3. And what we can appreciate on the MRI is at along with the subluxation, we also see that anteriorly there is a fluid which is seen at the C3, C4 disc level. So in this ankylosed spine, there has been a posterior subluxation of C3 or C4 along the disc line, and that has led to severe cord compression and cord contusion, which can be appreciated on this T2 weighted MRI image. Now here's a CT. So in CT, this shows that there is a fracture of the C3 vertebra. Along with that, you check for all the sagittal as well as parasag cuts, and then go for the axial cuts. In axial, we will be surprised that we can even appreciate a lamina fracture or undisplaced facet fractures, which helps us to plan our surgery well. Suppose the facet is fractured and it's an unstable fracture, then maybe instead of doing only an anterior job, we might have to do a 360 anterior and posterior job. So whenever feasible or whenever you feel suspicious, do all the three imaging, that is X-ray, MRI, and CT scan. Now CT or MR angio, why it is very important? Because if we appreciate this on this central image of the angiography, we can very well appreciate that on either sides, the internal carotid as well as the vertebral artery that is being seen. But the topmost right side image that we see, on right side, we see along with the internal carotid, there is another artery, which is the vertebral artery. But on left side, we don't see that. Now you come down to the axial image. Now in axial image, just along the vertebral body on the two sides, what we appreciate is circular things. Those are the vertebral arteries. On the right side, we can appreciate a black circular thing, which is actually the patent vertebral artery on the right side. Whereas on the left side, it's occluded white color thing. That is the occluded vertebral artery. Probably this patient had a vertebral artery injury on the left side, and he has developed and this patient has developed he has developed hematoma. So though the chances of this being symptomatic is rare, but if it becomes symptomatic after surgery, then we are in medical legal condition. We face medical legal conditions in such cases, and one has to be very careful in such cases. Now, once we know what the fracture is and we can appreciate that on CT, X-ray, MR, then comes the classification, how to classify. Now, this is a very old classification based on the mechanism of injury. Alan Ferguson classification, which is very good to know what kind of injury, how the patient has got. But what it lacks is it doesn't give us any insight about the neurology. It doesn't give any insight about how to manage these cases, and it just to know, to appreciate how the fracture occurs. This is it's still a good classification. So it can be of flexion compression type, flexion destruction type, vertical compression, or extension compression or extension destruction. These are various types. But as I said, there are some lacunae in this. What is more commonly followed is the AO and the next classification which I will be discussing. In AO, as we know, the classification is based on as is true for the lumbar and the thoracolumbar spine. The classification has all those A, B, and C criteria, and the similar thing is being used here. So what is A? A is the bony compression injury, B is the posterior ligamentous injury, and C is the rotational, to simplify things. Then comes the sub-classification. So in A, if there is no fracture, it's A0. If there is a wedge fracture, it's A1. If there is a just split, then it is A2. Now, what do you mean by split and burst? How to differentiate that? So, if the vertebral body, posterior part of the vertebral body is intact, then there is a fracture involving only the body, but the posterior part, the posterior column is intact, then we label it as a split. Whereas even if the posterior column of the vertebral body that is involved, that is fracture, we label it as burst fracture. Depending on whether the burst fracture involves only one end plate or both the end plates, it's termed as incomplete or complete burst fracture. Now coming to the tension band phenomena, type B. So if the bones are involved, it's labeled as B1. If there is posterior tension band injury at the ligamentous level, it is at 2, B2. And if there is anterior tension band disruption, that is a disc disruption, it is labeled as B3. And in C, there can be translation injury. It can be either in sagittal or in coronal plane. And then there are various add-ons like the facets, how the facets are placed, and what about the neurology? So neurology also, whether it is intact, whether it is transient, whether it involves a root, whether it is a complete, incomplete, or the patient is comatose. So all those things are taken into consideration. AO has also added few more things like whether the vertebral artery is involved or not, like in M4, and whether the patient has got some pathological bony lesions like ankylosing spondylitis or disc M3, that is M3, or whether there is a critical disc herniation M2 or posterior ligamentous injury with complete disruption. So all these things are added on just to grade the severity, so that we can actually, while communicating with the help of this nomenclature, we can actually communicate as to what the injury is, and it will help us to know the neurological status of the patient right now. However, this classification, AO classification, is very good to understand things, to communicate things, but it doesn't give us any idea as to how to proceed. Whether if the patient is having A2 or B3 lesion, then whether we should go in for surgery or we can conserve. For that, there's another classification which is known as slick classification. It's more of a scale, and it also takes into account all the three things: the morphology, the posterior ligamentous complex injury, and the neurological status. So depending on how the mechanism of the injury, the morphology, it has 0 to 4 points. Then depending on whether the ligamentous complex is intact or not, it has 2 points, and neurological status. So depending on from milder to severe, it's graded from 0 to 4 in morphology and neurological status kind of status. And once we add on the points, if the point is more than 4, definitely we have to consider surgery. If it is 3, you can always do a non-surgical management in these cases. And 4 can be individual, means based on the individual criteria, we can either conserve or operate on these patients. So above 4 is definitely surgery, less than 4 is non-surgery, and 4 is indeterminate depending on the patient factors, whether the patient want early mobilization or how bad the patient is. We can either conserve or operate on these cases. Now, these are the basic things that as an orthopedic surgeon, we need to know about how to check the patient, how to make a diagnosis and classify the patient, know about the scoring and determine whether to go for a surgery or not. Now comes the further part. Now, many times this is associated with other injuries. So that time we have to take a call whether this needs precedence or some other life-saving injury needs a precedence. Suppose we decide that cervical injury is the only thing that we have to attain. Then till the OT is being readied, if the patient requires, or if the OT is not thing, what to do, how to proceed. There comes a medical management. So first of all, immobilize the patient and patient, sorry for the phone. Yeah. And whether any role of medicines. So methylprednisolone is widely controversial, and the loading dose and then maintenance dose which was given over years and decades, it's a bit controversial whether the side effects are much more than the benefits. So the cost benefit ratio is really questionable, and presently in my practice, at least, I'm not following this since quite some time. And role of traction. So the traction helps to realign and stabilize the spine. The patient has to be placed in reverse triangular position so that reduction will be facilitated, and you have to apply the weight traction properly and go on increasing the weight, do serial x-rays, check out the pulse, check out that the patient doesn't go into bradycardia, and preferably do in a OR operating room, so that if the patient deteriorates, then we can directly shift the patient in OR. Avoid traction in under GA. So, and avoid traction in, especially if the patient has got any skull injury, or if there is a atlanto-axial or occipital-atlantal dislocation. The maximum weight that we can apply is just remember, with every vertebra increase the 5 pounds. So first vertebra 5 pounds, second vertebra 10, third vertebra 15, and so on. So that's the maximum weight that one can apply in an injured spine. Now, is there any role of conservative management? Yes, there is. Or not all the fractures are stable, unstable. So all those fractures which are stable, like the fractures which involves the lamina, the fracture which has burst stable, like the vertebrae, the posterior, the end plates are not badly damaged, or the fractures which get reduced, the facetal dislocation which get reduced. These are the cases which can be conserved. But the moment we conserve any fracture, we should always remember that if the reduction has happened, it's quite likely that we can lose the reduction which we have achieved. So prolonged immobilization in the form of brace or a halo is a must, and regular x-rays at every 3 months, 3 weeks has to be done. If there is any failure of the reduction achieved, then one has to intervene and go for a surgical management. Now, surgery. Now, like any other surgery, the goal is to have a very balanced and stable spine with minimal motion segments being sacrificed. And this helps not only to make the canal capacious, so that if there is incomplete injury, the patient will have better and maximum recovery of the neurological status. Also, in a patient who has been even in patient in whom the cord has been badly contused and there is no chances of neurological recovery, stabilizing the spine helps for early mobilization, for taking proper care, and that has to be done as early as possible. So if the patient has a progressively neurological deficit which is progressively worsening, we have to do this as an emergency case. All those complete spinal injuries or static incomplete injuries, that has to be done urgently. And neurologically normal patient with unstable spine, that has to be fixed as and when the patient turns up to you. Now, if we broadly see how to proceed in individual case, Like if there is a burst fracture, then the morphologic wise, if we revisit this chart of sleek classification morphology, in which 0 is no bony abnormality, 1 is compression fracture, 2 is burst fracture, distraction is 3, and any rotation is 4. Now, if we see principle wise, this is almost the same as what AO has classified from A, that is less severe, B moderate, and C severe most. So even the rotation element over here gets the maximum scoring 4. Distraction is the posterior band involvement, which is B in AO classification, and burst comes in burst is A4 and compression is A2. So if we see the logic, the logic of AO as well as sleek classification remains the same. From 0 to higher grade, it's always mild to severe most. So one has to see the morphology. So if there is a burst fracture, it's 2 scale here, it's A4 in AO classification. Both warrant surgical intervention. Then comes ligamentous injury. So if there is a burst fracture, ligamentous posterior injury might or may not be there, and the patient may or may not have neurological weakness. It might be a cord injury or it can be a neural injury. So depending on that, the score is been determined, and most of this burst fracture, they need surgical intervention. And because it's an anterior column fracture, we need to do an anterior reconstruction in these patients. Only in patients, mind you, only in patients who have concomitant posterior element injury or who have osteoporosis or pathological fractures, in the same setting, one has to do anterior as well as posterior fixation and give a 360-degree stability to the spine. Otherwise, in a young patient with a burst fracture, anterior surgery or anterior column reconstruction alone suffice. Next comes if there is a if there is a bifacetal injury. So depending on the morphology and the posterior ligamentous complex injury, we again have to check out if warrant surgical intervention or non-surgical. Most of these cases, they actually warrant a surgical intervention. Then we have to decide the approach. So if there is a anterior disc herniation into the spinal canal, we have to go for that discectomy. So the approach is decided: do anterior discectomy, anterior reconstruction, reduction and reconstruction and stabilization. Suppose there is no disc herniation, then one can opt for a posterior fixation. In this case, one has to be very careful. So if it's a young man with a very strong bone, then lateral mass will suffice. Lateral mass fixation will suffice. But lateral mass alone in osteoporotic bones might not suffice. So that might warrant posterior as well as anterior fixation. Or if one wants to go only posterior, then pedicle screws, cervical pedicle screws is the choice, because these are really very strong. They have very strong pull-out strength, so that will suffice. And pedicle screws are bit more are better as compared to lateral mass, especially if it comes to the collapse. So if we only do posterior fixation, there is always a chance that the disc which has disrupted anteriorly might further collapse over a period of time. So if there are pedicle screws in purchase, then the chances of collapse is lesser as compared to if we do only lateral mass fixation. So choice is yours, but one has to be very careful with what we are doing. Suppose in cases in which there is extension type of injury, in this cases, it's always surgical intervention which is needed, and one has to go for anterior fixation. Now, facet dislocation, whether it is unifacetal or bifacetal, let's see one by one. So if the vertebral body has failed in compression, then we need to check out whether end plate compression fracture is there along with posterior facet dislocation or not, whether the fracture is totally complete or not. So if the injury is more severe, then one has to go for anterior as well as posterior. Otherwise, we can just go for a posterior reduction and fixation. Now, suppose that there is no anterior body disruption, then again check out whether the disc has herniated or not. If there is no disc herniation, you can very well go for posterior. And again, the same thing which I told you before, that thing applies here also. And if there is a disc herniation, there is no option. We have to go anteriorly. And there are situations in which we come across the cases in which the facet has fractured. So even if we do a good anterior job, good discectomy, a wide decompression, release anteriorly, still the reduction is not being achieved, because many times the fracture fragments of the facets, they get locked and they don't allow the reduction to occur. So in such cases, after doing an anterior discectomy, one has to go posteriorly, do a proper reduction posteriorly and fix it at the same time. Then again turn the patient, come anteriorly, and then complete the anterior fusion job. So it will be anterior, posterior, and then again anterior. So all these things has to be taken into account, and it's always a tailor made approach that one has to take on table. And it's always better that if we have proper imaging, we should very well keep all our implants ready, so that if we are suspicious of a facet being blocked, and we suspect that we won't be able to take care of only one approach, then we keep plates, anterior plates, as well as pedicle screws or lateral mass screws on table, so that as and when required we can use those. Now the approach, the most common approach anteriorly that we follow is the Southwick-Robinson approach. That's the anteromedial approach, and it's very ideal for sub-axial cervical spine. It's a direct approach, and we can very well reach the vertebrae in no time. So this is a cross-section diagram, and the arrow which is being shown over here, the red arrow, this is how we have to proceed. Now, mind you, the green lines are the fascia and the red ones are the muscles. So nowhere we have to cut the muscles. Always take an incision medial to the sternocleidomastoid muscles. Then we have to look out for the strap muscles. Between the strap muscles and the sternocleidomastoid, dissect out the fascia. Once you dissect the fascia, then palpate the vessels. That is a carotid artery. Be very careful. And once you do that, again dissect the fascia, go medially as much as possible, retract all the midline structures, the esophagus, the trachea, and land over the prevertebral fascia. Once we land over the prevertebral fascia, that's the time where you have to incise. Yeah, sorry. That's the we have to incise the fascia right in the midline and retract the longest coli. That's the yellow star which is being shown. And also the landmarks. Before we take the incision, we should be well aware of the landmarks, the bony landmarks. The C3 vertebra coincides with the hyoid bone. The thyroid extends from C4 to C5, and the carotid cricoid cartilage is that matches up with C6 vertebrae. So once we are aware of it, accordingly we can take the incision. Once we take the incision and we land on the prevertebral fascia, incise it, then comes the marking out. Always remember, it's very likely that with the same incision, you can even go to C4-5 disc as well as C5-C6 disc. Just the tilting of your angulation, you can land up in the adjacent segment, the normal segment. So always, whenever you see the vertebra, take a K-wire, insert the K-wire on into the body of the vertebra, and then take a C-arm shoot, confirm your level, and then do the discectomy. Its slightest injury to the disc causes disc rupture. So even there are surgeons who have a practice of putting a needle, is a fine needle into the disc space and then checking out the level. I will ask you to refrain from this, because even a needle can actually cause disruption of the annulus of the disc, which can lead to adjacent segment disorder. Suppose you are in the wrong level. If you're on the right level, well, that's the level you have to go. So there's no harm done to the disc. But if you end up in a wrong level, puncturing of the wrong disc, then the patient will have an adjacent segment disease in near future. So one has to be very careful. So once we know the thing, then we can proceed and do the perform the surgical intervention as required. Always remember, cervical spine injury is very easy. It's relatively easy to operate. What is difficult is the post-operative care, because many times it's higher cervical injury, they have this respiratory muscles involved, and if the patient is not capable of maintaining saturation well, the patient will be on ventilatory support for a long time, and all those bedridden complications, prolonged ventilatory supports, morbidity associated with prolonged ventilatory support, need for tracheostomy, and then dependence on ventilator. All those things can happen, and that can increase the morbidity, the cost, and at times even cause mortality. So it's not a very easy thing to have, and the better if we diagnose this injury right in the beginning and have a tailored made approach to all the cervical spine injury, so that we give the best what the patient needs.
Yeah, thank you, sir.
Okay,
So.
great. So any questions? There was one question about a teardrop fracture from Dr. Avinash. How do you identify and what is a teardrop fracture?
So in teardrop fracture, I think I should have some. So in that, either the upper or the lower end plate disruption is seen, and it disrupts with the annulus. If the teardrop is actually only in the front and it's not associated with any other end plate, significant end plate or body injury, you can very well conserve these cases. But if it is accompanied with some subluxation, then the teardrop fracture that you see is along with the disruption of the disc, which is never going to unite of its own. So those things will need a surgical intervention, like a discectomy and fusion.
Yeah, it's called a teardrop because it looks like a teardrop on the X-ray on the lateral view. Okay.
So there are few questions from Dr. Kumar Gautam. You want to know when to do MR angiography, sir. So actually, we want to ask when to do MRI also. That is when patient comes with the cervical spine injury in the trauma. When you used to do MRI, or is it CT is also needed, or just trauma X-ray is okay?
So whenever the patient comes to you with a intact neurology, there is a fracture, but intact neurology and the facets are not dislocated, you can avoid doing a MR. But in every neurological injury case, one should do a MRI. CT also helps to know the cord status, but medically to be on safer side, always get an MRI done. MRI also helps to, even in the axial, as I have shown you in that slide, MRI also helps to know the status of the vertebral artery. So if the vertebral artery injury that is appreciated on axial itself, then there is no need for a angio. So that's why I prefer MRI.
And so when you diagnose a fracture on MRI, do you again ask for a CT scan to identify it better when you're planning for surgery? Like,
so in surgery, see, that's an ideal scenario, but usually the patient resists for all those cost concerns. So cost concerns is not an issue. Always get all the three modalities. Otherwise, X-ray, a good X-ray and MRI should suffice. Because in MRI, we check out even the posterior ligamentous complex injury. The posterior ligamentous injury is involved or not. We can even look at the vertebral arteries, and it also gives us idea of the level of cord contusion, the cord edema, and the disc herniation. So all this soft tissue injury, which we want an idea of, so that if we do only CT and don't do an MRI, so we can miss all these things. So if the choice is only one, I would prefer MRI. If I have a choice of doing all the three, any three, then I will do all the three.
There's a question asking about what is Trendelenburg position and reverse Trendelenburg position.
So in Trendelenburg position, the head is on the lower end as compared to the leg. So that's a Trendelenburg, and you do the opposite thing. That's a reverse Trendelenburg.
Okay, so I think a lot of
The questions are all.
people use that for lower abdominal surgery and things like that, the Trendelenburg position.
Yeah, and in cervical, in prone position, I do the reverse Trendelenburg.
Yeah, so you keep the head higher.
Yeah, because there is at times with the prone position, especially when you're working on the cervical, there are times in which this central retinal vein occlusion occurs, and that at times can lead to blindness. So in past we had some 3 cases of this. So ever since that we have learned our lesson. We keep it in reverse Trendelenburg position. Check out the eyes more properly. Keep it well padded.
And so when you apply the cervical traction, in that case, sir, what is the ideal position for the head?
See, the traction has to be applied with the patient in reverse in the Trendelenburg position, and the head you have to do the maneuver. So always, if there is a flexion injury, you have to first go on distracting in the flexion. So that the facet gets dislodged. Once the facet gets dislodged, then that time. So if this is the thing and it's flexion, so go on distracting it. Check it on X-ray. Once it is dislodged, then you do extension, so that it gets reduced. That's the thing.
And so for follow-up, like
so you should know
what is-
that's where that flexion, distraction, all those Alan Ferguson thing comes in. But in today's practice, if you want to operate, you directly go in. You don't go for traction.
Yeah,
like
I think I
in
can't remember the
last 14 years, I haven't done a cervical traction applied in cervical traction.
So
these cases
I think
acute.
so. We did some years ago. We did reduce some of these on traction and then put them into even cast sometimes in that position. But today you would go ahead and operate on most of these. The problem was losing your reduction if you just put them in a collar or something like that. And the other thing is what they write about in the books, where you gradually keep increasing the traction and watch and do it. That is, I think, something which I haven't seen anyone actually practice. It's there in the books, but I've never actually seen anyone actually practice that.
So we have done in our PGs. Ashok will tell us. We used to be awake whole night.
Yeah,
and get serial lectures of our own.
Yeah, so that's what I'm saying. I think today nobody really goes
After
through the
two.
process. Yeah. But it's probably important to know because it apparently did work for a lot of patients.
Yeah, and so for the DNB Viva, it is quite favorite to ask about the cervical traction.
Yeah.
Yeah, so remember that cervical traction is very important. Like if the patient comes with an intact neurology and there's no obvious disc on an MRI, you can actually go in for a good reduction and hope that the patient with serial X-rays every 3 weeks you can do. So this unifascial dislocation, for these cases you can go in for a conservative management with traction. And there's always there is a risk of disc herniation leading to neurological deficit. I think most of the time this disc herniation, while reducing it, it's more of a theoretical risk. And we have come across various forums even in which the cervical spine surgeons, like even from Europeans and the American society, they haven't experienced any time this disc herniation leading to weakness post reduction. So it's more of a theoretical risk of disc herniation leading to weakness in after reduction. That has to be kept in mind.
When the patient comes with facet dislocation, is it that cervical traction is indicated at that point of time?
So as I told you, if the plan is actually surgical intervention, in today's era, at least most of us just immobilize in a collar, hard collar, Philadelphia collar, prepare for the OT and get the patient table. But you immobilize, you don't ask them to just wander around.
So, there are a few more questions, like up to how many days cervical traction should be maintained?
So if you are going for non-surgical management, then cervical traction, once you achieve, you have to keep it for at least a couple of weeks, maybe even up to 3 weeks. Get the X-ray done. If the X-ray doesn't show any loss of reduction, then you put it in a hard collar, okay, or a halo. Then again at 3 weeks, that is at 6 weeks from the first day, again you repeat the X-ray, and that you go on doing till 3 months.
Someone's asked about the nexus criteria.
What criteria is it?
Nexus.
Sachin has asked.
So I will have to read it up. I'm sorry.
I think it's something to do with when it's to do with when you need to do X-rays or not. So there are a set of guidelines where if the patient is fully conscious, there's no, I don't know the exact details of it. Patient is fully conscious. There's no obvious tenderness. He can move his neck. There's no instability. Then you don't need to do an X-ray. It's like the ankle they had. The Canadian Orthopedic Association had a criteria for that, where you don't need to do X-rays when they come to the casualty kind of thing.
So the basic thing is you rule out clinically that there is no injury, cervical injury.
Essentially,
so,
I think it's to do with that.
So if there's no tenderness, no palpable spinous process step, okay, the neck movement is pain-free. The patient in lying down is able to lift the neck up and down, flex it without any difficulty. Okay, the neurologist is totally intact. It's not a transient loss. So there are patients in which there is a transient loss and they come back. So those need MRI. But if there is no, you're not even transient loss, the reflexes are totally normal, then you can be assured that there's no injury and you can not do a X-ray or MRI. But beware of things that planters itself can be upgoing at some cases just because of whiplash injury.
Yeah.
Okay, so planters can be upgoing, the reflexes can be abnormal, though there is neurologically intact. So such patients, you can't apply all the criteria. So all the criteria, neurologically has to be the inspection, palpation, and the neurology. Everything has to fit in, and you have to rule out that there's no injury clinically, and then you can avoid doing a X-ray or any other imaging.
So there's another question about MRI. This is from Henry Lutunde. I understand that MRI is necessary in cases with neurological deficit. Question is, when should it be done, or is it reserved only for stable patients?
So MRI has to be done in my practice. MRI has to be done in each and every case, whether the patient has neurological injury or involvement or not. So, and the earlier you do stable, I mean stable, if the patient is hemodynamically stable, yes, then we should do. But if the patient is hemodynamically unstable, one has to first be stabilized and then get the MRI done.
Yes, I mean, you have to go through the ATLS protocols of breathing, all that, airway breathing, etc. You're not going to do an MRI if the patient is gasping and about to crash on you.
Yeah, I think it is CABC, that cervical spine stabilization is the first thing before airway to consider.
No, that is not stabilization. That is
that
immobilization. So immobilize that thing, and then the rest of the things, like if there is another thing like a blunt, significant abdominal injury which warrants a surgical intervention, that time we are not going to go for MRI as a first place. So once the patient is hemodynamically
to
stable,
protect the cervical spine, though, so that you don't cause any further injury. But if he's already gasping, then you have to deal with that. You need to get on and, if necessary, intubate him or put in a chest tube or whatever else is necessary. You have to do all that.
Dr. Gautam has one more question. Like, what is the management? Dr. Kumar Gautam has asked, what is the management if there is vertebral artery injury?
So
Pray.
vertebral artery injury is a there is no evidence-based study to say how will you manage a vertebral artery injury.
Yeah.
Okay, so there are papers which say that once the vertebral artery injury is there, you go proximal to the injury level and ligate it. Okay, there are things in which they have even embolized. There are papers they have embolized it. Dissolved with streptokinase. They have dissolved the clot. Okay, so all those things are there, but even a repair of the vertebral artery that has been documented, but we don't have a definite answer as to what is to be done. So if there's an intimal injury, by the time you actually approach it, the intimal injury can actually progress further upwards. So all those things can happen. The first and foremost in your clinical practice to remember, if there is vertebral artery, try not to touch these patients.
Yeah.
Okay, I have lost one patient after doing the surgery, and after that I have stopped doing patients who have got vertebral injury. Okay, 4 of those patients which I have encountered at Paris, 3 have gone to Delhi. Okay, 1 expired, one survived, the 3rd I don't know what happened. So don't touch them.
So, Gautam has asked one more question about the MRI angiography. So, most of the things we are able to see on MRI. So, in any specific case, you have ordered MRI angiography for like when to order, like.
So in most of the cases, you come across all this in MRI itself. A good radiologist will help you read on a plain MRI. But if there's slightly of doubt, you go for an angiography. Now, if you have already done an MRI and you still have some doubts, then I would suggest go for a CT angio, because at that time you will get the CT as well as the angiography done.
Okay, I think that should do it for today. If there are no other burning questions, thank you very much, Gautam. That was an excellent session. And I hope the students have learned from it. And once again, see you again next week. You're back on the normal time, I guess, on Tuesday. And we will inform you accordingly. Okay.
Thank you so much, sir.
Bye.
Thank you.
Thank you, sir. Good day. Thank you everyone. Thanks, Janki.
Thank you, sir.
Thank you, Dr. Ashok.